everyone. Welcome back. I hope you enjoyed lunch. It was pretty good, I have to admit. Okay, so it's my pleasure to introduce our next guest, a skilled cardiothoracic surgeon who has been part of Eisenhower Cardiothoracic Surgery Specialty Clinic in Rancho Mirage for the past 3.5 years. Dr. Logsdon earned his medical degree from Louisiana State University School of Medicine and completed his residency at the University of Southern California. He's a board-certified thoracic surgeon. Fun fact, before pursuing his career in medicine, Dr. Logsdon earned an undergraduate degree in chemical engineering and worked in that field for several years. However, he found the work unfulfilling and decided to shift his career towards medicine, a decision he considers deeply rewarding. He believes his engineering background provided a strong foundation for his medical career and applies the analytical approach to his surgical practice. Dr. Logsdon has a strong passion for fitness and nutrition, emphasizing their importance to every patient is a key component of recovery and long-term well-being. Please join me in welcoming Dr. Daniel Logsdon.
Thank you. They usually put me in the morning because after lunch, you guys are going to be a little snoozy, but it's okay. I got a whiteboard. I get up. We do some activities. Thank you for the introduction. It's our 4th year doing this. This is just a great thing for Eisenhower and our new Cardiovascular Institute to be a part of. It's really informative as our community continues to grow and our practices continue to expand. I mean, the amount of people we treat here with cardiovascular disease, just since I started, has, we've grown over the last 5 years just in one area over 120%. So, I mean, we're treating a massive amount of disease and we're just now starting to make a kind of a dent in that. So one of the big things that most people have met with or have somebody they know who has is atrial fibrillation. So it's kind of a forgotten disease when it comes to more than just medically managing it, because for a long time, medical management works very well for a lot of patients. Who here has AFib or knows somebody who has AFib? All right, so just look around. That's pretty much 100% of people in here have that. And that's how prevalent the disease is. And we're taking a lot of unique approaches to treating that. And I think what we do very well here is that we combine what cardiology and our excellent electrophysiologists, some of them are speaking today, do on the inside of the heart with what our surgeons are capable of doing from the outside of the heart. And I think the outcomes we have in patients that had no prior treatment options have been tremendous. So this is my approach and the surgeon's approach to slowing down AFib. Okay. So this is a very cool video. So atrial fibrillation, I think, is best understood when you get to visualize it. So this heart here is going to be sinus rhythm. So let's take a look. Very nice. That's the lub dub you all know, right? And love, boom, 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 right? Is there a difference? Significantly. Which patient obviously probably feels better? The one in sinus rhythm, the one that's actually pumping blood, right? That's moving blood. That's the problem with atrial fibrillation, is that the blood is actually not moving. It's sitting. Your heart's fibrillating like this, and the blood doesn't move. That's why if you have AFib or know somebody who has AFib, they're on some type of a blood thinner, because when blood sits, it clots. And when clots happen in the heart, people have strokes. One more time around for everybody. Okay. So what you see on this heart here, you see a line here, right? This is what an ablation line looks like on the outside of the heart. Now, this patient has ablation lines multiple places, but this one is what's called on the right atrium. So an ablation line is scar tissue. So it's an area where you try to disrupt the abnormal electrical currents in the heart. And we do that by providing fences. And I think one of the best ways to understand this is how many people go on hikes. Everybody, right? We live out here. It's great hiking. And then there's always a trail, a common trail. Everybody's supposed to tread on the trail. And then some guy gets an idea that I'm going to like pull off and start going up this way, right? And the people behind him are like, yeah, it looks like the main trail. Let's keep going this way for a while, right? So they deviate off of the normal trail, right? So sinus rhythm is what you expect. It's where the normal trail is. And the other trail may lead you to a place you don't want to go, right? It takes somebody to come behind who knows how the trail should be to block that off, right? And they either put rocks in the way or they put sticks and they block it. So you know as you're coming by, if this is the first time you've been here, don't go that way. And so the ablation lines do just that, right? We take these abnormal electrical currents, we block off the abnormal paths so that you try to stay in sinus rhythm as best you can. Now, it's a little bit like whack-a-mole when it comes to blocking them, but we have some very good understanding of where the common electrical currents should be and where they shouldn't be, and where the common sources are of the abnormal trails. So that's what ablations attempt to do, is to block those. So AFib, a growing problem, right? You looked at this room, this matches what happens across the country. So currently about 8 million patients, and this data is probably 5 to 6 years old, with AFib that are diagnosed. And why is it a problem? If you know somebody who's had AFib, hopefully they haven't had a stroke, but oftentimes the way you find out you have AFib is you have a stroke, a 5 times greater risk of stroke, 5 times greater risk of going into heart failure. You've got a 46% greater risk of all-cause mortality. And I'll show you a slide in a minute about what that means. Approximately 1.2 million AFib diagnoses annually in the US, right? So we'll compare that to what it looks like on a global scale here in a minute. So how does AFib impact somebody's life? When we go back and we look at these patients over 15 months, they typically have 3 emergency department visits, 67 physician encounters. They can have up to 12 outpatient hospital visits based on some of the studies that are there. So it is something that not only impacts your quantity of life, so how long you're going to live, but grossly impacts your quality of life. So where does it line up in terms of mortality rates? So how prevalent and how deadly something can be? Well, you've got types of cancer. Pancreatic cancer, survival rate is only 4%, right? Based on this Medicare data. Brain cancer here, 7%. Lung and bronchial cancer overall, about 14.9%. Then you've got stomach and ovarian, and then here's AFib, right? Look where it falls above: breast cancer, colon cancer, things that we talk about a lot, right? So it's right here. It's number 6 on the list, 7 on the list, 6. So it's prevalent. It has a very high mortality rate on patients. And we're trying to approach patients and say, how can we impact this to move it down the list? Not only that, it has an impact burden, right? The cost of healthcare in this country, as y'all know, very high. AFib in patients costs a lot of money, a lot of visits. We've talked about that. So when you put somebody back into sinus rhythm, you're reducing their hospital visits, you're reducing the spend on patients, which overall improves their quality of life and allows us to have more economic impact globally. So a lot of risk factors with AFib. I'm not sure if somebody talked to you, but pretty much everything can impact AFib. Some of the things we don't talk about a lot, but it does. Drinking alcohol. If you have AFib, consuming alcohol increases your rate of AFib significantly, right? Obviously, smoking's on that list, right? Other heart disease, so you got coronary disease or valvular disease, all impacts AFib, right? AFib is driven pretty much by stress on the heart, and there's a lot of different stressors on the heart. So 3 types of AFib that we discuss. So we talk about paroxysmal AFib. About 30% of patients have that. And so that occurs occasionally and can last up to 7 days. So these are the people that, yeah, I was in AFib, but now I'm out. I'm in, I'm out. So it's very inconsistent, but it's there, and it's enough to cause a problem in terms of a stroke rate. So those patients go on an anticoagulant. Then we've got something we call persistent AFib. So it's longer than 7 days, but less than a year. Okay, and about 25% of patients there. And then you've got this long-standing persistent AFib, which is the majority of our patients are there. About 45% of patients, once they have AFib, they stay in AFib forever, right? And over time, if we look at what that does, and this is kind of a progression model, and this The problem with AFib is that it's not going to kill you tomorrow or the next year, but over time, and this time scale here, what I'm showing you is over the course of 20 years, the impact that AFib will have on your body, right? So as you see this, what we're showing is that this red line here is remodeling of the heart, right? The heart's muscle. So you go to the gym and guess what happens? Your muscles remodel, right? Bigger upper body, bigger glutes. People like bigger glutes, but it requires you to work out, right? So when you're in AFib, that heart muscle's not contracting. So your heart and your body naturally begin to remodel, right? But in AFib, that takes time. Just like going to the gym takes time. You go hit the gym tomorrow, you're not going to have big biceps right away, but you hit the gym over and over and over again, you're going to see an impact, right? That's how it works. AFib is very, very similar to where it's not tomorrow that it's a problem or a year, but if you've been doing this for 10 years, you start to see remodeling of the heart muscle. And then the other thing we hear is the progression of the risk factors that are associated with AFib. Those begin to increase as the remodeling increases, okay? And look, we're talking 10 years out. We're talking these people that the 45% of patients that have had AFib and aren't able to return to sinus rhythm, 10 years into that, they're starting to feel the effects of the AFib. And so that's why it's so important to begin offering options to treat this, because just medically managing it over time and leaving people in AFib doesn't prevent the remodeling. So what is the remodeling, right? We talk about it. How many people here have heard like, oh, I knew somebody who had an enlarged heart? Everybody, right? I'm like, that doesn't tell us anything other than the heart is bigger than it should be. Well, what we see in AFib is exactly that. And there's some fancier words that we put to that. We put in chronic diastolic heart failure. We talk about systolic failure. But overall, all of those have led to remodeling of the heart and the progression you see here. So take a look at this heart. Somebody who's in no AFib. Look at very normal heart size chambers. But as you begin to progress through the AFib pathway, you begin to see the remodeling happening, right? And that's what that chart was showing you. So this happens over the course of 5, 10, 15 years. You begin to see that. And then when you get to this spot out here, right, it's getting to the point where you can't even do anything to treat that heart. The heart muscles have dilated so much that we can't get them to return back to normal function. So we need to begin treating patients in here. So again, like I mentioned, long-standing persistent AFib is an untreated group that we have been aggressively treating here at Eisenhower. So we talked a little bit about how AFib happens. And again, I'm a chemical engineer. I like pumps, pipes, and fluid flow. I am not an electrical engineer. But what you see, and I'm going to draw it up here for you, you can see how these mechanisms begin. And they usually, and we're going to get into anatomy just a little bit, which is going to be a little boring, but they typically affect the left atrium of the heart. That's our primary focus point. And it's primarily around the pulmonary veins. So I'm going to do a little drawing of this and we'll talk about it. And then we'll kind of go into like how we treat this. So this is looking at the back of the heart. This is the left atrium, okay? And you have pulmonary veins here and here. You've got two of them on each side that come in and drain, all right? The primary source of AFib people are in paroxysmal AFib occurs around these veins, here and here. And our typical mode for treating that is endocardial ablation. What does that mean? So if you have anybody who's ever come in for an ablation, you've come into the EP lab or the cath lab, wherever they do it, they come in and they're going to treat typically the pulmonary veins. We know that the primary source of people in paroxysmal and early AFib comes from here. About 80% of it comes from there. So we go on the inside, and just like I showed you on the outside, we create isoelectric lines. We create that scar tissue. Okay? And that works very, very well. But again, just like that hiking trail, sometimes you have people that fall off that trail and make another trail down the road. And that's how we start to progress towards persistent and long-standing persistent AFib. So a little bit of a picture of how the endocardial ablations work. So there's a couple treatment mechanisms that we use that were mentioned earlier, probably in a talk, but we've got two things we do. So we can either burn it to create the scar tissue, or we can freeze it. And now we have a new technique called pulse field ablation that we're doing here that allows you to go inside and pretty much create that scar tissue very quickly and eliminate those abnormal signals. So what you see here is you see pulmonary veins. This is inside the pulmonary veins, and there are two treatment options that we have for it. So what have we found from the data? So I've kind of told you all this for two reasons. One is you need to understand the disease. You need to be informed on what it is. Two, you need to understand like what our basic treatment mechanisms have been for a very long time. And it's been treating with endocardial ablations. What we've begun doing here at Eisenhower is combining what we do on the inside to the outside of the heart, which is what I'm going to talk about now. How do we go about treating the AFib that doesn't get treated with endocardial ablations? So what this chart shows you, right? And only thing you need to look at is the color. So it shows two things. So it shows catheter ablations of long-standing AFib and 5 years outcomes. So what it looks at here. So this is somebody who's had their first ablation, okay? And this is their freedom from AFib. So initially, right, great treatment options. But as you start to progress over the years, right, with an endocardial ablation, we begin to see that just one ablation is oftentimes not enough on the inside. And then we come back and we do another ablation oftentimes. So you see this here. This is after multiple ablations on the inside. And this data holds up across a lot of different metrics. A lot of different studies have been done. And so you got about 40 to 50% of people who have long-standing AFib, endocardial ablation has not been successful long-term. So another study kind of showing the same thing. And so what we've looked at was, all right, how do patients do with different types of catheter ablations? And again, if you start to look at this chart, the most important thing to understand is just treating the inside of the heart over long periods of time, right, only gets you about 40 or 50% success rate. And I know if I'm an AFib patient, I'm not super happy about a 50% success rate. So that's just kind of what brought us to where we are now. So again, conclusions. Limitations associated with endocardial ablations of the left atrial posterior wall, which is what I showed you there. You have high recurrence rates, concern for fistulas, so there can be some risk factors associated with that. It's very low, but there are risk factors there. You've got unique structures in the epicardium that can sometimes impair how the treatment works from the inside. So treating from the outside and from the inside can provide benefits. So what does that look like? So now we'll get to the surgeon part, right? So now we'll get to surgical AFib. We've been doing it since 1980. Dr. Cox invented this thing called the maze procedure. And so they spent a lot of time in a lab. They went and looked at all the different ways and mechanisms where AFib comes from, right? And so they developed a map on where these ablations go. So when you come in for open heart surgery, where we open the chest, we perform a maze procedure. So we perform multiple ablation lines around the heart. So you see there's pulmonary veins here, right? So not only do we do this, right? But what we do is we create a box around this. Okay. We do this. We also treat your left atrial appendage. There's a line that comes in here. Okay. And then there's a mitral line that you don't see, but there's a mitral line that we sandwich between. So there's there on the left side. So we do multiple different lesion sets here. And then we go to the right side and we also do 3 or 4 different lesions there. And that has been defined as a gold standard of how to treat AFib, but it's very extensive. We have to open your chest. We have to open your heart. We have to stop your heart to do it. So if we're going in to fix a heart valve or do bypass surgery, we'll do that. But nobody's signing up to have their chest open just to get their AFib treated. It's not how we treat it. So what we have tried to do is take what Dr. Cox, and I know him, he was at WashU in St. Louis. He's still there. And so he still comes to a lot of our meetings and we still talk about how we treat this. And so what we've created is a hybrid ablation technique. We are trying to mimic the gold standard of treating everything without having to open your chest. We want all of the benefits here with minimizing the risk. That's what we try to do in healthcare, right? We know how to treat things, but we want to minimize the risk and increase the recovery so you get back to doing what you were doing before. So we've come up with a few techniques that help us mimic that with similar, very positive results. So that procedure is called the convergent procedure. I don't know if there's any patients in here that have had convergent. There's one. You had convergent? Yes. And? There you go. Okay. So good. How many before? Yeah. Okay. Yeah. So, that's excellent. That's excellent. So this is what we're trying to accomplish here. We're trying to take somebody who has long-standing persistent AFib, 10 cardioversions, right? So that first slide I showed you, how many hospital visits they have, there's an example right there, right? We're reducing that number significantly. So how are we doing that, right? So we're trying to recreate where the most important parts are that we can accomplish from the outside that is very difficult for the cardiologist to get from the inside. So what cardiologists have become very, very good at, right? They have become very good at treating the pulmonary veins. They're really, really good at treating the pulmonary veins. They do an excellent job. Their outcomes here at this hospital are excellent, right? So they're very good at treating the pulmonary veins. So let them treat the pulmonary veins, right? Very good at treating the roof line here. We call this the roof because it's the top, right? Keep it very simple. Very good at treating that. The challenging part from the inside of the heart is treating this area here. And a lot of the recurrent AFib, so if you go and study these patients, if you go look at where the AFib comes back, and one of the ways we do that is we map the electrical activity of the heart. So we actually go in, when you have a convergent procedure, we actually map the electricity here. We can map it and we can see the conduction in the heart. And what we see, a lot of the recurrence rates occur here. And so we've designed a procedure such that we can treat this space right here. And it does two things. One, it provides a very good ablation line that prevents any signals coming from this area. The second thing it does, it helps our cardiologists who go back in on the inside to treat any residual disease that's there. It provides a very good platform for them to build upon for future ablations on the inside. And that's what we're showing there. Oops. So how do we get there? Well, we have to get to the heart. We're heart surgeons. We don't know what to do if we don't see it. So what we do is we make a small incision below your breastbone. You see that on the left here. So normally what we have to do is we have to open up your chest all the way down. We actually come below your sternum, so you can feel it. It's called your xiphoid. We come below your xiphoid. We make about a 2 or 3 centimeter incision here. And we come up underneath the heart. So we open up the pericardium, which is like the bag that the heart sits in, and we're able to come in from behind. And when we do that with a camera, we're able to see that exact picture that I drew for you, right? That's why we can draw it so much as surgeons. We see it every day. That's exactly what we see. You can see that here. Here's your pulmonary veins, and we come in and we perform an ablation across in between these veins just like this. We don't have a lot of grass out here, but if you ever mowed grass, it's very similar. You just do this, you just make lines. It's actually, from a surgical standpoint, it's not very stimulating, but it's very, very effective. So if you can mow grass, you can do this procedure. So here's an example of the back of the wall. So what I'm starting at, so if you look at the left side of my drawing here, it's going to look like mush up there. My camera is looking right here, okay? And I'm going to move this way so you can see it. The heart usually is pink tissue. You can see the pink tissue up top there, and you see the dark kind of charbroiled tissue. That's the ablation. So there's a pulmonary vein right there on the left side of on the right side that you see on my drawing right there, but it's actually the left side of the heart right there coming across. So you can see we've ablated the tissue completely across between those veins. Much easier, much quicker than could ever be done on the inside of the heart. So I talked to you about electrical maps, right? Here's an electrical map of the heart. Look at what we create. You guys can see, if you look at this picture here real quick, look at that. What do you see? Exact same drawing, right? Recreating that drawing with electricity. Here it is. We've recreated it. This is before the ablation. So we're measuring millivolts, right? This is just a voltmeter. If anybody ever does electrical work, you're just checking voltages, right? These are very small voltages, but we're measuring voltages. Look at this. Look at the color. Looks like a hurricane here when these people are in AFib. Afterwards, we remap it and we confirm complete blockage. We're one of the first sites to map every one of these patients. What we're doing here that we started about 3 years ago has now taken off across the country, because I said, how are we not mapping these patients and guaranteeing the results? All the trials were done without ever mapping. And what happens is when you map patients, you can identify exactly where the areas are. You go through and you treat them. So you don't over-treat. You go through, you treat, you map. If there's something there that we see, if there's color that we see, and it lights up right here, guess what we do? We go back in and we hit just that area. We have places across the country that spend almost 2 hours, 2.5 hours doing this. This procedure takes us about 40 minutes, and we have perfect results because we don't leave the room until we guarantee we have it. And so what we're doing here has changed what all the other sites are doing. Mapping is becoming gold standard, but we started it here. And I have to give credit to our EPs. What are they? The 3 of them. They do a lot of mapping, and they showed me the mapping they did on the inside. And I said, why can't we do that on the outside? And they said, oh, you can. I said, well, let's do it. And so they kind of helped me learn the process of mapping. And now it takes us about 5 minutes to create a map, maybe, but the amount of information it provides is tremendous. So one of the other things that we talk about is strokes with AFib. And so what comes with this convergent procedure and the hybrid approach is management of the left atrial appendage. So this is an appendage, okay? They all look different. They're like fingerprints. Every one of you have a different looking appendage, which is a little frustrating, but this is the appendage. It sticks off the backside of the heart. So when you're laying down in bed, the lowest part of your heart is your left atrial appendage right there. And so blood sits there. So when you are in AFib, like I showed you before, and you're not moving blood, it pools back there. The primary source of stroke comes from left atrial appendage. So when we go in there, we go in and we manage the appendage. And so what do? We actually, as a surgeon, we place a clip on it. So we just pinch off the entry point. And what that does for patients during that procedure, and here it is. Here's the clip in white. Here's the appendage, okay? It takes about 15 minutes to do. It eliminates your stroke risk completely, all right? You can come off of your anticoagulation, and it provides that isoelectric line that we used to do surgically. It provides that for you during that procedure. So here you go. So you see the white is open. What you're gonna see now is I'm gonna release it, and it's gonna close. There it goes, and it's pinched off. That's it. Done. Case is over. We've managed that. So during the case, we also do the appendage management. Other ways we do the appendage management can occur from the inside. It's called a Watchman device. I don't know if we talked about Watchman yet today, but Watchman device goes and plugs it from the inside. So that's something cardiology does. But what comes with the convergent procedures, we manage the appendage from the outside. So what we've done, we've looked at the trial, and I'm going to show you some of this data over here. And I'm going to tell you because it's hard to see. So 40% is the line without convergent. We're averaging about 70% here success rate, and you'll see it down here as well, about 70% success rate of taking people who are 100% in AFib and returning them to sinus rhythm. So this is the trial data. Our data here that we've collected on over 100 patients aligns with this just about almost perfectly. So not only with this procedure do you stay in sinus rhythm more than any other option you have, but you also reduce your need for antiarrhythmic drugs, amiodarone, flecainide, diltiazem, drugs that some of you are probably on. We reduce the need for that significantly. So I'm going to stop there because I'll talk forever. Everybody knows that. So I think there's somebody else who's going to come speak after me. But if you guys have questions about this, want to learn more, reach out to us, reach out to our AFib group. We're happy to talk more. We're happy to see you in consult. It's very easy to get in to come see me. So it only takes about a week if you need to come in and see me for AFib. So thank you so much. I got support slides that you don't need to see. So thank you.